Good morning. Thank you for joining us this beautiful morning. My name is Gemma Kim, Program Manager. We are so excited to having Dr. Erin Salinas overview of gynecological cancer presentation. Before I introduce our presenter, I'd like to say a few words about Asian Cancer Resource and Support Services at Asian Health and Service Center. To address the health disparities caused by cultural differences and gaps in health beliefs and perceptions, we have recruited and trained bilingual and bicultural cancer patient navigators and volunteers who can share their cancer journeys and engage personally and culturally with the patients and their family members. Our goal is to be bridge between cancer patients and their family caregivers and medical providers. We hope to not only establish communication, but also promote collaboration and coordination to reduce the unnecessary stress for everyone and increase positive treatment outcome. We have been providing cancer resources, information, and referral and care coordination with the treatment providers, emotional support through peer support, nutrition consultation, and counseling services in Cantonese, Mandarin, Korean, and Vietnamese. Our cancer fighting volunteers have not stopped reaching out to people who have been affected by cancer during this pandemic. Their courage and effort have been touched many hearts and empowered cancer fighters. We ask your continuous support and encouragement so we can continue our cancer journey together. On behalf of my team and volunteers, we thank you, Dr. Erin Salinas, presenting this important topic this morning. Let me introduce Dr. Erin Salinas. Dr. Salinas specialized in gynecological oncology with expertise in advanced laparoscopic and robotic surgery, complex pelvic surgery, abdominal debulking surgery, and minimally invasive fertility-sparing surgeries. She treats all gynecologic cancers and has a strong interest in clinical trials and the genetic links to GYN cancers. Dr. Salinas is committed to building open and honest relationship with her patients. She takes a comprehensive approach to ensure her patients are supported on every level by an integrated care team to treat the whole person, not just the cancer. When not working, Dr. Salinas enjoys spending time with her husband and daughter. She loves soccer, the outdoors, hiking, road biking, camping, and traveling. Please welcome Dr. Erin Salinas.
Okay. Thank you so much, and thank you for the invitation to present today, as well as for all of the good work you and your team are doing in the community for our patients and those that are affected by cancer, made much harder over this past year with COVID. Limited resources, limited number of people that can come into the clinic, so it's just been harder all around for patients and providers. So thank you for the work that you're doing and the invitation to talk today. I'm just going to give a general overview of the different gynecologic cancers, the main ones that we treat. Next slide. I have no disclosures. Next slide. So I'll plan to review the most common gynecologic cancers, which will be endometrial cancer, ovarian cancer, vulvar cancer, and cervical cancer. I'll discuss surgical principles of gynecologic oncology and discuss risk factors, presenting symptoms, and the management of the different gynecologic malignancies, and go over, kind of what to expect and what we see with treatment. We're as GYN oncologists, we're one of the last field that does both surgery and our own chemotherapy, which is really nice because it allows us to meet patients and then follow them over time. You know, they're not meeting multiple different doctors, one for surgery, one for chemotherapy. You know, we are that one provider that provides all of that and can establish relationships with the patients and their families and allow that ongoing relationship with them. Next slide. So the first cancer I'll talk about will be endometrial cancer. It's also known as uterine cancer. Next slide. This is our most common gynecologic cancer. It's also the most curable gynecologic cancer that we encounter. It's the fourth most common cancer for women in the United States, and 75% of these occur after menopause. Here is a picture of the uterus, and the endometrium is the inside lining that, I don't know if I can point, but the inside lining there of the uterine cavity, and that's where endometrial or uterine cancers arise. Next slide. So it's pointing there to the inside lining of the uterus. There's three different types of endometrial cancer, type 1, type 2, and then a genetic predisposition to uterine cancer. So the three types that I'll talk about. Type 1 is our most common endometrial cancer, and it's caused by overestrogen, so too much estrogen, either in the form of taking estrogen, adipose cells, or obesity produces estrogen that can cause endometrial cancer, or there's certain medications like tamoxifen that's given. It's an anti-estrogen in the breast, but a pro-estrogen in the uterus. So there's different causes of excess estrogen that can lead to endometrial cancer. This is usually caused by a precursor. So we'll see hyperplasia or complex atypical hyperplasia that can be a precursor to this early uterine cancer called a type 1 or grade 1 endometrial cancer. Sometimes we can treat these hormonally, but if it progresses to cancer, then the recommendation in patients who are healthy enough is to undergo surgery. Next slide. Again, the causes of increased estrogen, obesity, and ovulation just means you have abnormal cycles, either from PCOS or other reasons that would cause you to have more estrogen formation without a normal period. Exogenous estrogen use, so tamoxifen, or if someone has a uterus in place and they're taking estrogen only without progesterone. There's also tumors that can produce estrogen that can cause overestrogenation. Next slide. There's a second type of endometrial cancer called a type 2 endometrial cancer. These can be classified either as high-grade endometrial cancers or serous, uterine papillary serous carcinomas, or clear cell carcinomas. Those are the different histologies in type 2 endometrial cancer. These are more aggressive cancers. They're usually treated with a combination of surgery, chemotherapy, and radiation, and have an overall poorer prognosis, but are still very treatable. They're more commonly associated with advanced disease, meaning that the cancer has spread to other areas at the time of diagnosis, as opposed to the type 1, which are almost certainly confined to the uterine cavity when we meet people with this diagnosis. Next slide. The third type is associated with hereditary syndromes that put people at risk for endometrial cancers. The most common is hereditary non-polyposis syndrome, which puts people at risk for most commonly colon cancer, and in females, uterine cancer. The sentinel cancer in 50% of people is colon cancer, and 50% of women is an endometrial cancer. So we try to take a thorough family history to see if people will qualify. We use the 3-2-1 rule. So more than 3 relatives that have one of the associated cancers, which uterine cancer or colon cancer, or in a smaller degree, actually ovarian cancer can be associated with this too, at about 12% risk. Other associated cancers would be small bowel cancers or urinary tract cancers. And so the probability of someone who's diagnosed with HNPCC increases when these cancers are diagnosed at an early age. So more than 3 relatives, one of these cancers and diagnosed at an early age. The other thing that we're doing for all patients that are diagnosed with endometrial cancer is we're testing their tumor for something called microsatellite instability, or MSI. And if the tumor itself has this microsatellite instability, then it triggers us to make a referral to the genetic counselors to see if there's a genetic link to the cancer that's identified. Next slide. These are the different cancer types associated. As you can see, colorectal is the most common, with an increased risk of 30 to 60% of developing colorectal cancer in a woman's lifetime, and a 60% chance of developing uterine cancer in a woman's lifetime. So those are the two most common cancers. And then ovarian cancer is also a 12% risk. Next slide. The most important part for uterine cancer is early detection of endometrial cancer. This is a picture description. When anyone comes in complaining of bleeding after menopause, it always needs to be evaluated. So anyone that has bleeding after they've undergone menopause, or if they're younger but have very abnormal bleeding, meaning heavy periods or bleeding in between periods, warrants an evaluation that usually starts with an ultrasound, where they measure the thickening of the inside lining of the uterus. That should be less than 4 millimeters. If not, then we need to do, this is an office procedure where we place this little straw-like biopsy pipette into the uterine cavity to withdraw tissue to evaluate for endometrial cancer. If we're unable to do that in the office for whatever reason, then we need to proceed with something called a dilation and curettage, or a DNC, to get that tissue diagnosis. That's the only way to diagnose endometrial cancer is on tissue. So we really need that biopsy to know what we're dealing with. Next slide. And again, we're able to find these early just because most people present with postmenopausal bleeding, which cues us to get an ultrasound and to do a biopsy. This is a picture of a uterus, and in that very inside lining, you can see the abnormal cells there that look like a little piece of popcorn. And that's a uterine cancer confined to the inside lining of the uterus. The standard of care in patients that are healthy enough and wish to do so is to undergo surgery. And this can be in grade 1 uterine cancers that are confined to the uterus. This can be curative, just simply removing the uterus. We also remove the tubes and ovaries at the time of surgery. The other thing that we've started to do is we need to evaluate lymph nodes. We used to take a lot of lymph nodes from a certain area, but it came to an up to 10 to 12% risk of chronic swelling called lymphedema in people's legs that can severely affect quality of life. So what we found is that doing something called a sentinel lymph node biopsy, where we inject the cervix with a green dye at the beginning of the case and then use a special camera to map out the first lymph node. And I'll have a picture of that. The very first draining lymph node turns green on the left and right, and we remove that first lymph node. And if that is negative for cancer on pathology, then there's a 99% chance that every upstream, meaning all the other lymph nodes are negative as well, by plucking out that first one. The risk of lymphedema with this type of procedure is much less. Next slide. So the standard of care for uterine cancer is to do minimally invasive surgery. There have been lots of studies that have shown, that there's no compromise in cancer outcome for minimally invasive surgery versus an open surgery. And actually there are better outcomes because the recovery time is significantly less, and patients recover easily when we do, more easily than when we do big open surgeries. So here's a picture of us doing a robotic hysterectomy. That's the robot there. We plug the ports into the patient's abdomen and then attach the robot, and then the surgeon goes and sits at the console. The picture in the upper right is what it looks like. It's really great because you have 3D visualization and can see really clearly. That's a picture of the major blood vessel with a lymph node being peeled off the top of it. The bottom right corner is a picture of the console where the surgeon sits after we've set up. Next slide. Next slide. So we do a total hysterectomy, which is removal of the uterus and cervix and removal of tubes and ovaries, and in fancy doctor words is bilateral salpingo oophorectomy. This is just a picture of the different attachments of the uterus, cervix, tubes, and ovaries. And then on below, this is the robotic visualization. In the middle there, you see the uterus, and then coming off the sides are the fallopian tubes, and then the little white things are the ovaries there. And we detach all of those from their surrounding structures and attachments, and typically can remove the specimen from the vagina. Next slide. When we used to do the full pelvic lymph node dissections, the lymph nodes, from the pictures you can tell, these are little fat pads that sit on the major blood vessels. So this, is a very tedious operation and can take many hours because we need to peel the lymph nodes off of the major blood vessels. And you obviously don't want to injure the blood vessels, so you just have to very carefully peel these off. So what you're looking at are the major blood vessels up to the pelvis, called the iliac vessels, and then also the ureter, the tube that connects the kidney to the bladder, is there. And that's where and the obturator nerve is also labeled down deep. So you peel these out of a general region off of these major structures. And there's, not a lot of room for error because you're so close to these vital structures. Next slide. A para-aortic lymph node dissection is where we remove the lymph nodes even higher up off of the aorta. And that's a picture of the aorta, the major blood vessel, and in the bottom right corner, the little yellow fat pad looking tissue, or the lymph nodes that are being peeled off of that general area. Next slide. The mainstay of treatment now is the sentinel lymph node biopsy, and that's where we inject the dye. There's decreased operative time and complications, decreased morbidity and risk of lymphedema. A really excellent false negative rate of only 3%. The thing is, you do need to use a Firefly system, which most commonly comes in on the Da Vinci robot. And this is a picture here of me in Firefly mode, where we injected the dye, and that's the first lymph node, and you can see it draining into that. And so we just remove one lymph node rather than multiple lymph nodes. Next slide. Once we do surgery, usually, not always up front, but we usually do surgery for endometrial cancer, the decision of whether or not to give additional radiation, chemotherapy, or hormonal treatment to women with endometrial cancer is complex, and it really depends on the type of cancer. Those type 2 cancers we talked about, the serous or clear cell, almost certainly need chemotherapy and radiation. And then also the extent of cancer or the stage of cancer. Stage means, has the cancer tried to make its way out of the uterus? If it's spread to the ovaries or the lymph nodes, then that makes it a stage 3 cancer, and those are almost always treated with a combination of surgery and chemotherapy, with radiation and chemotherapy. And also we look at the risk factors within the uterus itself, and sometimes people qualify, even with these early grade cancers, to have radiation to the top of the vagina called vaginal brachytherapy to decrease the risk of recurrence. The most common place that endometrial cancers come back is the top of the vagina. So we will either radiate that area or follow patients closely, usually every 3 to 6 months, with pelvic exams to make sure that cancer is not trying to come back for up to 5 years. Next slide. So stage 1 endometrial cancer, meaning confined to the uterus, more than 90% of patients will be cured with surgery alone. It's less common for this to spread outside of the uterus. Next slide. Again, treatment of advanced disease. So if someone comes in and a CT scan shows that the cancer is outside of the uterus already at the time of presentation, then sometimes we will do an open procedure to debulk that tumor, meaning remove all visible tumor. Sometimes we'll start with chemotherapy in this situation to shrink it so that we can do surgery. A lot of times people will have heavy vaginal bleeding from the uterine cancer, and we need to do something called a palliative hysterectomy, meaning remove the uterus to stop the bleeding. Radiation therapy is an option in these patients. Immunotherapy has recently been approved in recurrent disease settings, and then there's also clinical trial is a really great option for anyone who presents with recurrent or advanced endometrial cancer. I run our clinical trial at Compass Oncology for all the gyne cancers, and we have a really great clinical trial right now open that's offering the standard of care chemotherapy plus or minus an immunotherapy, and then also plus or minus a PARP inhibitor that they're using in ovarian cancer. We're extrapolating to see if those would be beneficial in endometrial cancer. Next slide. There's a couple other types of uterine cancer. I'll just mention these. So we talked about the endometrial cancer that arises from the inside lining of the uterus. There's some cancers that can arise from the muscle of the uterus, that outside layer, so not from the inner cavity, but within the muscle itself. And these are called sarcomas. So leiomyosarcomas, or stromal sarcomas, or carcinosarcomas, which are a combination of the two. Anytime someone has what we consider a rapidly growing fibroid should be evaluated because there's a chance that it could be a sarcoma. Next slide. Our next cancer we'll talk about is ovarian cancer. Next slide. This is difficult to diagnose. Typically, patients present at later stages because of this. The symptoms are very vague. 90% of ovarian cancers arise from the lining of the ovary. Where now newer data is pointing to that a lot of ovarian cancers are actually fallopian tube cancers. There's different types. Serous, I highlighted clear cell because this clear cell ovarian cancer is more common in the Asian population. Mucinous, endometrioid, or even ovarian carcinosarcomas. There's another 10% of ovarian cancers that arise from the inner lining, the inside lining, called the stroma, which are granulosa cell tumors that these produce hormones. And then the least common, and usually in younger patients, there's something called germ cells tumors that arise from the eggs of the ovary itself, called dysgerminomas or immature teratomas would be examples. But the most common type of ovarian cancer that we see and that I'll be talking about moving forward is the epithelial ovarian cancer, most commonly serous, but also clear cell. Next slide. You can click there. So what symptoms would make you concerned that your patient might have ovarian cancer? And you can click one more time. Yep. So typical symptoms of ovarian cancer. The reason, these are pretty vague and come on quickly so people don't really notice because they're everyday symptoms that you're like, oh, I feel a little bit bloated, or have decreased appetite or get full really easily, have abdominal pain or reflux symptoms, increased urinary frequency, significant actually weight loss or weight gain because these cancers can make fluid called ascites that will cause you to have rapid weight gain. Nausea, vomiting, or shortness of breath, but most people are actually asymptomatic, meaning they do not have symptoms at the early stages of ovarian cancer. Next slide. Staging of ovarian cancer. Stage 1 is limited to the ovaries. Stage 3, this is how up to 50% of patients present as with stage 3 disease, meaning it's in the upper abdomen as it presents. Next slide. We are also finding that ovarian cancer can be linked to genetics. Most are sporadic, meaning they happen for we don't know why, but they're not based on genetics. In about 10% of people, there's genes that can lead to ovarian cancer. We talked about the HNPCC earlier that's associated with colon cancer, uterine cancer, and ovarian cancer. But then there's other genes called BRCA or BRCA that are associated with breast cancer and ovarian cancer, most common. Next slide. So the BRCA1 gene, there's a 40%, up to 40% risk of ovarian cancer and up to 65% of breast cancer. In BRCA2, it's a 10 to 20% risk of ovarian cancer and 55% risk of breast cancer. So these numbers are not small. That's up from 3% in the general population. So we try and identify patients early who have these mutations, meaning, are there people in your family that have early onset breast cancers or multiple breast cancers or anyone with ovarian cancer? We're actually testing all patients now with ovarian cancer for BRCA to see if we can then identify family members who there's a 50% inheritance pattern So if we have a patient who has a BRCA mutation, we then recommend testing their family members, because if we can catch someone that has a mutation before they actually have cancer, there's options for what we call risk reduction, either medications to decrease the risk or surgical removal of the tubes and fallopian tubes and ovaries before one would get cancer. And so those are risk reducing surgeries and different options. We're also doing increased screening, so pelvic ultrasounds and checking a blood test called a CA-125. And then for decreasing risk of breast cancer, offering prophylactic removal of the breast to decrease that risk. So there are options if we can identify these patients early and then, offer surgical removal of the tubes and ovaries, usually by age 40 in BRCA1 or by age 45 in BRCA2, and that has a 90% reduction in ovarian cancer risk. Next slide. Next slide. The treatment of ovarian cancer is usually a combination of surgery and chemotherapy. The goal of surgery is to remove all visible disease to less than 1 centimeter, called an optimal debulking surgery. If we think we can do that up front, then we'll typically do surgery first, followed by chemotherapy. If for whatever reason, depending on the location of the tumor, we don't feel that that's possible, meaning if it's in the mesentery or the blood supply to the intestines, then we cannot remove that up front, or a lot of times if it's in the liver, that would be a contraindication too. So we'll give chemotherapy first to shrink it, and then we'll go in after 3 cycles of chemotherapy or 4, and then do surgery and give additional chemotherapy afterwards. But typically we do 2 different chemotherapies, one called carboplatin and one called paclitaxel are our most common gynecologic cancer chemotherapies. The surgery is usually an open surgery, meaning an up and down incision on the abdomen, because these are much larger surgeries than are necessary for uterine cancer. And then other things that we're using targeted agents as well. Bevacizumab or Avastin is something that we're using in certain patients. We can also give the chemotherapy into the abdominal cavity, called intraperitoneal chemotherapy, if people qualify. And newer is PARP inhibitors. So we used to just treat everyone with 6 cycles of chemotherapy and then wait. And now we're looking at maintenance therapy, meaning can we give people something after this chemotherapy to maintain the cancer being gone? One of those options is Avastin, which is a targeted agent that decreases blood supply to tumor. The other thing that's newer are PARP inhibitors. There's different PARP inhibitors, and these are pills that are used as maintenance therapy that are very, very effective, especially in patients that have BRCA mutations. Next slide. So ways to improve treatment for ovarian cancer. Patients should be operated on by a GYN oncologist to get the appropriate surgery and treatment. So referral to a major cancer center or GYN oncologist rather than a general gynecologist doing the surgery. Better chemotherapy, so looking at different options given through the IV versus given intraperitoneal, meaning into the belly. And then there's newer targeted agents, the PARP inhibitors, as well as maintenance therapy. The other thing that we're doing is molecular profiling. So testing all patients with ovarian cancer who agree to move forward with this is testing them for the BRCA mutation, the patient itself, and then also testing the tumor to look for different targets so that we can personalize cancer care and say, okay, this patient's particular cancer has these molecular targets or these mutations, and then we can target those and hopefully be more effective in treating the cancers. Next slide. Many side effects come with treatment of cancers, and that's why, at Compass Oncology, we have a comprehensive team where we have nutrition, we get palliative care to assist with symptom management very early on. And really this needs to be approached as a team approach to treatment. With surgery, these are big surgeries and there's increased complications, especially in people, you know, a lot of times in cancer patients, you can't eat well, so your nutritional status is low, and then it's harder to heal from these major surgeries. Or you need to undergo multiple surgeries, and each time you undergo a surgery, there's more scar tissue and higher risk of complication. And sometimes to remove the tumor, unfortunately, these are on the intestines or in different locations, and they require an ostomy, or, you know, a bag on your belly to have bowel movements. In order to remove the tumor, we oftentimes have to do things like that that are either temporary or permanent. Or if it's a younger patient, loss of organ or function, if we need to remove the uterus, tubes, or ovaries, that induces surgical menopause and makes people unable to bear children. And then chemotherapy has side effects. It targets actively dividing cells. So we think of the GI system and the hair and the bone marrow. So patients lose their hair, may have GI side effects. And then the bone marrow, meaning those blood counts go down. So we have to watch people carefully with laboratory values to make sure, you know, that their counts aren't going low enough to necessitate transfusion or decrease the infection titers, so people are at increased risk of getting sick while they're on chemotherapy. Next slide. The next cancer I'll talk about is vulvar cancer. Next slide. The vulva is the outside of the vagina, and it's one of our rarer cancers. And it's usually also in older females, and most of the time is confined to the vulva in 86% of patients. The chance of developing this cancer is significantly less, only 0.3% of women. Next slide. What's interesting about vulvar cancer is there's a gap between patient complaining of symptoms and diagnosis. These are often diagnosed as other things, and people, they did a study and showed that people usually see 3 different doctors prior to someone biopsying the vulva to make the diagnosis of cancer. So by the time I see these patients, or that they're referred to me, they've often seen multiple doctors and been dealing with this for more than 6 months. Next slide. So if anyone presents with a vulvar lesion that's persistent, the recommendation is to do a biopsy. If people present sometimes with precancers, and you can have itching or pain or irritation, the recommendation is to do an exam to evaluate the size. If cancer is identified, then we usually also evaluate lymph nodes. And then if there's a cancer there, we need to see, can we remove it surgically? Meaning if the problem is if it's close to the urethra or the anus, then sometimes we can't do surgery to remove it without compromising one's ability to go to the bathroom. So we sometimes have to do chemotherapy or radiation to shrink it to the point we can do a surgery for them. Next slide. So the vulva is there in the middle, and usually the lesion presents there. The most common place that these drain, the lymphatic drainage, is actually to the groins. So just there in the groins onto those vessels. And we do lymph node evaluation of those lymph nodes once we have a diagnosis of vulvar cancer. Next slide. So the first step is we do a radical excision. These can be compromising just to appearance, because we need to get, they recommend trying to get 2 centimeter margins around the cancer, and then sampling the lymph nodes. We've also moved to sentinel lymph node evaluation in certain patients to decrease the risk of swelling in the legs. So we inject a dye and remove that first lymph node in the groin, again to evaluate with sentinel lymph node biopsy. If there's positive margins on the cancer, then we usually need to do radiation. If there's negative margins and negative lymph nodes, then usually no further treatment is recommended, just follow up. If there are lymph nodes that are positive, then typically we recommend treating with pelvic radiation. Next slide. Advanced vulvar cancer, meaning a cancer that can't be primarily resected because it's invading important structures there, like I mentioned previously, the urethra or the anus, or metastases to the lymph nodes or further. Then sometimes we treat with chemotherapy up front or radiation up front. Next slide. The last cancer that I'll talk about is cervical cancer. Next slide. This is typically found in younger patients. It's mediated by the HPV virus in not all cases, but the majority of cases. This should be able to be prevented with routine pap smears to detect precancerous lesions before they become a cancer. And also now there's an HPV vaccine that's effective against the most virulent strains that cause cervical cancer. So we are seeing a decrease in the number of cervical cancers. It's the most common gynecologic cancer worldwide, but not in the United States because of the pap smears and HPV vaccine is more prevalent here in the United States than in other countries. The treatment, it really depends. This gets complicated. If it's a small cervical tumor, the recommendation is to proceed with surgery up front. If it's any bigger, meaning if it's 4 centimeters greater or looking at a combination of different factors, then we've really found that treating with primary radiation therapy with weekly chemotherapy that's just a low dose to make the radiation work is better treatment. We're also finding, unlike in uterine cancer, where doing minimally invasive surgery does not compromise cancer outcomes, but there's newer data just in the last couple years saying that doing minimally invasive surgery, meaning laparoscopic or robotic surgery for cervical cancer, is not indicated. We've moved back to doing these all through open incisions, meaning big incisions on the abdomen. And these are radical procedures. They're not regular hysterectomies, they're radical hysterectomies. And I'll go over that in the next couple slides of the difference because it's a higher complication rate and higher side effect rate with these radical surgeries. Next slide. So just prevention, pap smears and the HPV vaccine. The pap smear schedule, they just changed that a couple years ago and then rechanged it. They've just changed it again about how often people should get pap smears. But it's on an every 5 year, every 3 year, every 1 year, depending on your risk factors. And up to age 65, unless you've had a history of abnormal pap smears, then we proceed past the age of 65. Next slide. So here you're looking, there's on the right, when you look at the cervix, when you put the speculum into the vagina and visualize the cervix, it looks like a little donut hole, and that's a picture of a cancer that's confined to the cervix and typically would be treated with radical surgery. On the left there is the different staging. So in stage 1, it's confined to the cervix and is based on the size of the tumor. In stage 2, it started to spread just away from the cervix there into what we call the parametria. If that's the case, this makes surgery very difficult because major structures that go to the bladder and the bowel and the nerves make it very, very difficult to get negative margins around that without significant complications. So anytime it's past stage 1, we treat these with primary chemotherapy radiation. Next slide. That's just the staging system for cervical cancer. Next slide. So treatment by stage. In very early cervical cancers, we can treat these with just a regular or what's called a simple hysterectomy, and we do not need to sample lymph nodes. Anything higher is treated with radical hysterectomy and a lymph node dissection. Next slide. So this is the difference between a total hysterectomy up top and a radical hysterectomy. The radical hysterectomy is just meaning we need to get much wider margins around the cervix, which looks easy on the picture, but it's very difficult because major blood vessels and nerves and the ureter, the tube that connects the kidney to the bladder, all run in that direction. So you really have to get all of these structures out of the way. And then you also remove the upper 1/3 to 1/2 of the vagina, which can lead, if you look at that bottom picture, with significantly shortened vagina after these radical surgeries. These come with up to a 20% complication rate of any type, and then patients need to go home typically with a catheter in the bladder for 1 week after a radical procedure. Next slide. We are able to do, so these happen in younger patients. And so removing the uterus would make them unable to carry their own children. So there are options for fertility sparing surgery where we just remove the cervix and the upper vagina, and then we reattach the uterus to the mid portion of the vagina and put a cerclage in. This means that you would, the pregnancy rate after this is pretty good. 2/3 of people are able to have babies after this sort of procedure, but they do need to deliver by cesarean section. Next slide. Radiation for cervical cancer, since this is common, I just wanted to touch on it a little bit so that people can understand the side effects. So we radiate a certain area, and because of that, that's why people may have side effects related to their bladder or to their bowel, because in order to accompany the lymph nodes and the cervix and the surrounding area, you inevitably get some radiation to the bowel and to the bladder. Next slide. So side effects with radical surgery: impaired bowel or bladder function, the swelling in the legs called lymphedema, or fistulas, which is an abnormal connection between either the bladder and the vagina, or the stool and the vagina, where people, or the rectum and the vagina, where people can leak stool or urine from the vagina and need additional surgery to fix that, and can be a real impairment on quality of life. Radiation is given with something called sensitizing chemotherapy. So it's not the type of chemotherapy that you imagine that we give with the other cancers where you lose your hair. It's more of just a low dose chemotherapy that's given once a week during the radiation to make the radiation treatments work better. So the dose tolerated depends on the organ, and people have early side effects such as diarrhea, nausea, vomiting, skin irritation, or fatigue. And then late side effects can be radiation cystitis, which is impairment of the bladder. Again, fistulas with radiation and or bowel obstruction. Next slide. So there's a couple new advances that are helping minimize side effects and increasing survival and treatment. We have found that adding bevacizumab, the anti-vascular formation immunotherapy, can improve survival when given in advanced cervical cancer. IMRT is a more focused form of radiation where we can use CT scan and MRI to see exactly where the bowel and bladder and everything is, and try and limit that radiation to just the area that we're trying to get and minimize side effects. Recently, immunotherapy for cervical cancer was approved in patients who were testing the tumor now for something called PD-1 positivity. And we found that patients that have this PD-1 positivity respond really well to immunotherapy, specifically one called Keytruda. And now, again, we're doing open surgery over minimally invasive surgery for people with cervical cancer. So uterine cancer, we do minimally invasive surgery. Cervical cancer, we've moved to doing an open approach. Next slide. And that's it, actually. That's all the most common gynecologic cancers in a brief overview. And so I'll be open to questions.
Hi, this is Anita. Thank you very much for giving us such a comprehensive overview of the cancer treatment. Can you give us some little tips on how to decrease our risk of endometrial cancer?
Sure. So the main risk of just the most common endometrial cancer is really obesity. So being healthy and losing weight. They've seen, even with gastric bypass surgeries, that we're seeing, oh, am I muted? No. We're seeing decrease in endometrial cancer. So decreasing obesity, and then making sure if you're on hormone replacement, if you're on estrogen, if you have a uterus in place, to really be taking progesterone as well to decrease that risk. We're also seeing that people with nulliparity, meaning that haven't had children, are at increased risk. I'm not encouraging people to have children, but if you do, you're at a lower risk. And then also identifying those patients who have hereditary link to uterine cancer and finding them early, and if they have Lynch syndrome, removing the uterus by age, tubes and ovaries by age 45-ish.
The other thing is actually, I really appreciate Compass Oncology because I've been referring patients to your genetic counselor, and they've been very, very good at, taking care of the patients. I really appreciate it because it's actually very difficult to get the patients to see genetic counseling as well as getting testing. So I do think that people should be aware of it because it can be done. Thank you.
Yeah, I agree with that too, because a lot of times by the time I've met the patient, it's a little too late. I see patients with cancer, and so by the time they get to me, they have cancer already, and then we're referring them to the genetic counselors to have their family hopefully have a decreased risk. But we really need to work better in the community with patient awareness, primary care, family practice, OBGYN awareness to take a full family history and try and find these patients early and recommend genetic counseling before they're diagnosed with cancer. Just because, by the time I see, we can affect the family, but not necessarily the patient. So identifying people early and having patient awareness to say, oh, I have quite a bit of cancer in my family. Maybe I should seek a referral to genetic counseling. And just because you have a meeting with our genetic counselors who are excellent, doesn't mean you have to get testing. They go over, they do a family tree, they do your cancer history, and then give you a risk evaluation to see if you would even qualify for genetic testing, and then also go over different risk concerns with the genetic testing. And some people choose not to have it, and some people choose to have it. But I think having all of the information is definitely good for patients.
Thank you.
Dr. Salinas, could you share a little bit about your experience working with Asian cancer patient and family members? How what was helpful and how we can guide them?
Yes, I think there's definite cultural differences in treating Asian patients, and a lot of it goes into knowing what they want to know. So sometimes I think protecting the family member with cancer, and sometimes they want to know everything versus sometimes the patient doesn't want to know as much. So entering into that conversation of what do you want to know, what do you know, who do we go through, and then also the language barrier. We have translators present with all of our patients who don't speak English or who request a translator. So we have translators, but I still think with cultural differences and the language gap, it just can be harder to understand the different recommendations. So that's why I'm so fortunate to have your services and appreciate that all that you do, because I really think, especially our gynecologic cancers, it's difficult treatment, and sometimes the prognosis in different cancers is not great. So having a community support and people to support you and help you understand and make these decisions is of utmost importance. And patients do better when they have that support system in place.
Thank you. And this Q&A is open to everyone, so you can, if you feel comfortable, you can show your video and you can unmute yourself and asking questions. And so we learn through asking questions, and so we are welcoming you to have questions. And then this is great opportunity to learn firsthand the information from our oncologists, doing all the surgery and treatment and everything. So we have one question in the chat box. And so the question is, if a lump was found in one of the ovaries and was removed, will there be a higher chance to develop lump or tumor in the other ovary? Does it need to check annually on other ovary?
Not if this was a benign. So very commonly people have ovarian cysts. If they're benign, then there's not a significant increased recurrence risk. If there's a family history, if this was a borderline tumor or a cancer where the other ovary was left in, then yes, we follow borderline tumors, cancers, or family history by evaluating the other ovary. but if it was a benign cyst on the ovary without those other factors, then no, we usually, if someone were to have increasing symptoms or pelvic pain or bloating, then we would reevaluate at that time, but nothing routinely.
You have any other questions? We have
Thank you very much, Dr. Selina. The information was very, very impressive. I'm not so sure whether I could understand the full picture, but just try to understand just the main point. Because I am working as social work, so if there is anything from social work or community to build some kind of a collaboration to protect people who might face having that kind of a cancer, and working with you and medical professionals to better provide any kind of a support from the community side. Is there anything you can share with us?
I think it's just awareness and preventative strategies, and I tried to touch on some of those. You know, the routine getting healthcare with routine Pap smears, knowing that if you bleed after menopause, to get evaluated sooner rather than later. And so just having different, if there was a way just to make community awareness of different symptoms to look for, and then the genetics portion to say, oh, I have this in my family history, or I'm having postmenopausal bleeding, or I need to get routine Pap smears. I feel like there's a gap between the medical community and you know, just people in the community, just because I don't know about other things, you know, so it's hard. I would have no idea to know what to do with law or business. So I just think there's a gap. So making community awareness somehow of these things. And oftentimes women specifically, especially when they have children and are very busy with children, women are known to put off their own needs and delay in diagnosis. And so I think just saying if something's not right, that it's okay to see a doctor and express concern.
I have another question. So during this COVID pandemic, I know that a lot of people just delay and put off their regular screening schedules, and they just keep postponing. And so what are your, you know, some of the recommendation or encouragement for all of us during this pandemic?
Yes, there have been some studies specifically in gyne cancers where we're seeing people present at later stages, meaning the symptoms were ignored, and by the time they saw us, that we're seeing more later stages of cancer, which means it's harder to treat and the prognosis is poorer. So anyone that's having symptoms, we're recommending being evaluated. It's the going to the doctor. At the beginning, it was a little bit scarier, but now that we understand the virus, we're able, in one of the safest places I feel is in the hospital and in the clinic, because we employ all mitigation strategies. So we've really found that wearing masks and doing the screening decreases. I'll knock on wood, because we haven't had any major outbreaks and have been seeing patients for over a year now in our clinic. So it seems like going to the doctor is actually one of the safest things you can do, because we're implementing these strategies. We're not letting people in if they don't have a mask. We're providing masks. We're doing temperature screenings. And most healthcare professionals are vaccinated with both vaccines by this point. So at the beginning, yeah, it was a little bit, nobody knew what to do. But now, you know, we're living in this pandemic for a year, and going to the doctor or the hospital is one of the safest places. We're screening all of our patients before any procedure, any surgery. So.
I have a question in the chat box. Will it be a higher chance of developing cancer if you're taking contraceptive pills more than 3 years?
So the answer to that is no in relation to gynecologic cancers. We've actually found that taking contraceptive pills decreases the risk of ovarian and uterine cancer. So we recommend that in patients who are diagnosed with the BRCA mutation. We recommend taking contraceptive combined oral contraceptive pills to decrease risk of ovarian and uterine cancers. There's still the question about increased risk of breast cancer, and I don't think we know that we know that estrogen does not increase that. The question is whether or not progesterone does, but it's still safe for women to take oral contraceptive pills unless they have a history of breast cancer.
Could you elaborate a little bit more how these contraceptive pills lower the risk of gynecological cancer?
Yes, they just suppress the ovaries, meaning it's ovarian suppression, and so decreased risk of ovarian cancer because those ovaries have been suppressed, just like having children suppresses your ovaries for that amount of time that you're pregnant, and so that also decreases risk.
Mm-hmm. Okay. And there's another question: is there any specific diet is to help good for prevention?
We don't have anything specific, but we know that processed sugars are really kind of the worst thing, but we haven't been able to identify exactly which diet. But we know that cancers are diet specific because we see different cancers in different parts of the world. So there has to be a dietary component. I usually tell people to avoid refined sugars.
Okay. And we have Dr. Anita Chen, OBGYN doctor, and then the Professor Johnny Lee. Thank you for joining us. And I think Dr. Chen has a question or comment.
Yeah, thank you, Erin, for sharing the information on the birth control pill. I think it is a very common concern. People are very worried about taking birth control pill because of that. But the other thing that I really got a lot of questions on is, how do we screen for ovarian cancer? And I'm sure you are the expert to give everybody a little view of your own.
Yes. So a lot of people ask this question, and unfortunately, there is no good screening for the general population for ovarian cancer that we've developed yet. For people with BRCA mutations, we're screening with pelvic ultrasounds and CA-125, which is a blood test called a tumor marker, every 6 months. And we're still finding that even that hasn't really improved prognosis, but it's the best that we have. But in the general population, there is no screening. We found that doing the pelvic ultrasounds, and this is actually, you find more things on the ovary, and there's more unnecessary interventions, more unnecessary surgeries, because you inevitably find something on the ovary that ends up, the risk of surgery or those additional interventions is more than the actual risk of cancer. So in the general population at this time, there is no screening for ovarian cancer, which is part of what makes it difficult. So that's why we're trying to find the people that have that hereditary genetic link and identifying those people and either screening with the ultrasounds and CA-125, but really removing their tubes and ovaries. Is the best that we have at this point. But hopefully later we'll get to something a little less barbaric than just removing the organ that can cause the problem. But at this point, that's where we are. Good question. Thank you.
There is a couple more. How about long-term contraceptive pills taking since young age, about 20s, and any harm?
No.
All right, and then there is another question. When I scheduled the woman health checkup, I thought the client would have a cervical check and pap smear. However, she was told she had exam last year and her insurance did not cover. How often women should get these types of screening?
So pap smear is typically only done every 3 or 5 years, depending on, it used to be done yearly, but now it's every 3 to 5 years, unless you've had history of abnormal pap smears. Actually, I'll defer to Dr. Chan regarding a pelvic exam. I thought that these were approved yearly in all women.
Well, actually, what happened is the College of Family Practice, family physician do not recommend pelvic examination as part of the annual examination. So but all insurance actually cover for yearly checkup except for Medicare. So the rest of the actually, until now, it is you are actually covered yearly for women exam. And you can pick it either a family doctor or a gynecologist. But Medicare is the only one that actually absolutely do not pay for annual examination. So.
And yeah, and just because you get a pelvic exam doesn't mean you have a pap smear. A pap smear is where we actually take a sample from the cervix, and that used to be yearly, and now it's every 3 to 5 years, depending on your history.
So I see that if you go to your family physician for an annual examination or annual medical examination, they will only do a pelvic exam when they do the pap smear. But if they don't need the pap smear that year, they will skip the pelvic examination totally. But of course, if you see a gynecologist, we all do pelvic, right? Just in case. But unfortunately, the pelvic examination is not a good screening test for ovarian cancer. But it's certainly, you know, especially for older folks, they never look at the vulvar area. So you pick up actually VIM. I mean, the pre-cancer stage of, vulvar cancer, which I actually pick up quite a few over the years because of that. It's just because they come in for an annual examination, we check everything, and we found lesions in the vulva, not the cancer, but the pre-cancer. And then we end up doing, a local excision, and they never develop the vulvar cancer. So it is not a common cancer, but it's certainly something that most people actually miss.
Yeah, I agree with this, and they're much easier to treat. It's so nice when these are found at a precancerous stage because it's a much simpler, it's an outpatient, like 30-minute procedure that's way less involved. So when these things are caught at precancer stage, they're so much easier to treat. And I actually, just doing screening for uterine cancer surveillance and ovarian cancer surveillance, I pick up quite a few vulvar lesions as well.
I think, anyone have any question? I know someone unmuted, so.
There's one more about given birth more likely to develop ovarian or uterine cancer. It is a risk factor. Nulliparity, meaning not having children, is a risk factor, but it's on the lower end of risk factor. It doesn't increase your risk significantly, but we have found that for some reason, having a pregnancy and a child and even breastfeeding does, and I think it's all in that you've suppressed your ovaries. And so therefore that decreases risk of ovarian and uterine cancer just because of that period at which point you suppressed everything. And there's another with COVID vaccine.
Yeah.
Yes, we have seen, there's a couple of things with the COVID vaccine. That's a good question. Yeah, we've seen not, prolonged change in menses, but it can cause, it's an inflammatory reaction. So anytime someone has surgery or now the COVID vaccine, any inflammatory reaction can delay or make your menses different for that cycle around the vaccine. The other thing we're seeing with the vaccine that's making our lives a little bit more difficult right now is it's causing enlarged lymph nodes as an inflammatory reaction. So when they've now recommended pushing mammogram out 6 weeks from COVID vaccine because they were getting false positives. And now when I'm doing PET scans and CT scans and checking CA-125, we're seeing a bump in the CA-125 and we're seeing these lymph nodes light up on PET scan, which makes it really confusing for cancer care. But we know enough now to say, oh, if you've had the COVID vaccine recently, then you'll probably have a swollen lymph node in your armpit or in the upper abdomen that's almost certainly secondary to the COVID vaccine.
Any other question? Mary, do you have a question?
No.
Okay. I have another question. I think there is some misunderstanding or myth from the people about someone said I'm not sexually active, and so I may have a low chance of having this or that. And any relation with that the sexual active and inactive that matter?
The only cancer that's related to sexual activity is cervical cancer and some types of vulvar cancer that can be mediated by HPV. And so that's an infection, but the problem with HPV infections is it can be an infection that you got even 50 years ago. And then it lays dormant and reactivates at a later time. So someone may not have been sexually active for 5 or 10 years and still develop a cervical cancer from an HPV that they were infected with many, many, many years ago that has just laid dormant and for whatever reason decided to all of a sudden show up. So we still recommend screening despite sexual activity.
All right, we're supposed to end this presentation at noon, but I will just wait for if there is any more questions from anyone, and I will wait and then see if no one raised their hands, then we can end our presentation. And we really thank you for Dr. Erin Salinas that making this time, preparing the slides and preparing this presentation and give us this great presentation. We really thank you. And we feel really encouraged, and our staffs and volunteers and patient and family members this will be a great opportunity to learn and increase our awareness about these important topics. And so we really greatly appreciate it and thank you. And this morning we have many staffs and also Dr. Eric Sito, our board chair, and Dr. Anita Chen attended this presentation. And also I saw the Christine Lau, our Chief Operating Officer, attended this training. So Dr. Sito, do you have any words to all of us?
No, I think this is well done. Thank you, Gemma, and thank you, Erin. And I'm sure this will make our cancer program very effective, especially to the Asians who usually do not have such information. Thank you. And especially, of course, we will translate this lecture to other languages so other people will be able to understand much better.
Okay, thank you.
Yeah,
Christine, do you want to say a few words?
Just want to say thank you. Thank you so much for the information and everything. Thank you.
Okay. And Dr. Erin Salinas gave us permission to upload this her presentation in our ACRES YouTube channel. Now we have ACRES YouTube channel, so you're welcome to go and visit. And we are working on adding a lot of good presentation. And also we are adding subtitles in different languages. And so thank you, Erin Salinas, to give us permission to upload this video in the YouTube. And thank you. Thank you, everyone. And enjoy your rest of the day.